Is your next slide a title?
Yep.
We're gonna leave that one up, are you okay with that?
Yeah, that's fine.
Okay. Yeah, perfect. Stand by.
Good afternoon, everybody. I'm Roger Bernowski, the Dean for the College of Rehab Sciences here at the U of M. And it's an honor today to have Dr. Justin Pisa as our speaker for our Illuminate series. And today he's going to be talking about hearing healthcare and providing some insight, I think, into the value of audiology in the future, what's going on. Dr. Pisa is an audiologist and a coordinator with the Surgical Hearing Implant Program. He holds affiliations with the Central Speech and Hearing Clinic and the University of Manitoba's Laboratory for Surgical Modeling, Simulation, and Robotics. He is currently a director of the Canadian Academy of Audiology and serves on a number of regional committees tasked with streamlining the audiology referral process and reducing surgical wait times for all patients. So please join me in welcoming Dr. Pisa.
Thank you very much. Okay, thanks everyone for attending. I hope you had a nice long weekend. And for the 10,000 viewers online, I appreciate your attention. So the last part of that little description was probably the most important pertaining to this talk, as my work with the surgical implant program here at Health Sciences Center is sort of eclipsed by a lot of the other work that we do within the region and the province for trying to streamline our service delivery protocols for audiology. So I'm going to talk mostly about that today, but there is a little bit of device information related to cochlear implants and bone-anchored hearing devices, since that is my area of expertise and I do like talking about it. So just a brief disclosure, part of my work with the robotics and modeling, surgical modeling lab, we do have a research grant through one of our primary cochlear implant vendors, but it is related directly to the work we do on our temporal bone models. So I'll dive into that a little bit more in more detail later. As an overview today, I'm just going to talk a little bit about how the world of audiology has evolved in the last decade. I'll give you kind of a snapshot picture of how things looked about a decade ago. And then talk about some positive changes that we've made over time. So hopefully that'll be encouraging. I'll try to make the snapshot of a decade ago as bleak as possible so that my talk sounds better than it is. After that, I'm just going to review a little bit about some of the hearing technology that we implant here at Health Sciences Center, and then follow up with just some results that we've collected from the audiological community, several programs, to show some of the positive benefits that we've been able to reap from these changes. Feel free to stop me at any time with questions. So looking back around 2010, I'll kind of paint a picture of how things looked for kids who may have been diagnosed with hearing loss, or a problem may have been detected in their speech and language development. So we had, 2010, no universal screening program at birth for hearing-related issues. Several U.S. states, most U.S. states by that time, had implemented a program. Many Canadian provinces as well. Manitoba, unfortunately, kind of lagged behind in that area. So what that meant was that kids who may have had a hearing issue at birth weren't really being picked up until later in life. They may have missed some developmental milestones that their parents have noted. Possibly their family doctor or another allied health professional might have picked up on, that prompted some further assessment in the audiological realm. But we're talking about kids who were likely 18 months of age or older, and that's a significant delay built into their progress at that point, depending on the degree of hearing loss present. So typically after a wait time, the child who may have a hearing-related issue would be screened by either an educational professional, a community audiologist within their regional health authority, And many times that child would be referred to either St. Boniface General Hospital here or Children's Hospital for full diagnosis. And that was after an additional wait time. Then further along, they would wait some more and before they could see an ear, nose, and throat doctor to figure out exactly what the next steps were with regard to any medical intervention or hearing aid work. So this meant for a lot of kids that we weren't really getting to the treatment part of the process until they were well over 2 years of age, which again just prolongs their rehabilitative process once we do actually fit them with hearing aids or implant them with a device. Excuse me, as I said, the child would then be fit by a regional health audiologist with hearing aids. The rehabilitative work would begin, or they were sent out of province for implant surgery. The distance, generally Newfoundland was one of our destinations due to their unlimited device budget, or Toronto periodically. However, that represented a hardship for a lot of families, whether they were elderly or pediatric patients. And so our actual implant rate was much lower than it is now in Manitoba, meaning a lot of people opted out due to the added stress of that scenario. Further, around this time, the Non-Insured Health Benefits Program, or the federal health coverage for Indigenous populations, provided no assistance for any implantable technology costs. So the cost of upgrading the equipment was entirely up to the family. And further, our provincial hearing aid subsidy program, which is designed to help parents provide hearing aids every 5 years for kids, didn't recognize a bone-anchored hearing aid as a quote-unquote hearing aid. So there was little help for parents, non-Indigenous parents. And as you can see, the costs of these devices are extremely expensive, $10,000 per ear for a cochlear implant processor and around $4,000 for a bone-anchored hearing device. So what has changed over the past decade? I'm going to highlight some positive aspects. I'll start off with our robotics and simulation laboratory, as mentioned earlier. So this was created around 2006. We've amassed about $900,000 in funding from government and non-governmental agencies to date. I'm highlighting this because this work was integral to the otolaryngology residents here at HSC in learning how to perform the type of surgery needed for cochlear implants. So what we did is develop virtual and physical 3D printed models of the temporal bone, that bone right behind your ear, and that has allowed the surgeons to demonstrate competency in that area prior to establishing our hearing implant program in 2011. So that enabled us to have a consistent annual budget to implant up to about 40 cochlear implants per year and around 15 or so bone-anchored hearing aids per year. Those are done right here at HSC and Children's Hospital. In 2013, we worked again with the region and Manitoba Health to institute a cochlear implant sound processor replacement program. And that is a program that helps parents across Manitoba by subsidizing the cost of those processors. So about 45% of our kids are implanted bilaterally. So that means every 6, 7, 8 years, they're saddled with a $20,000 or so cost of replacing those external pieces. This fund will provide up to 80% of those costs. So the parents are responsible for about $4,000 in total. And that's good every 4 years up until age 18. Finally, in 2016, we got our universal newborn hearing screening in Manitoba. That legislation provides the opportunity for screening within 24 hours of birth. The legislation specifically calls for the offer of a screening. However, our acceptance rates, as you'll see later, are extremely high. Coincided with that program was the Specialized Services for Children and Youth, or the SCI Center, and that's a building located just further down Notre Dame. And that is a center that was designed to enable parents to come to one place for a variety of different modalities, developmental, cognitive, speech and language delays, hearing issues. So it's a centralized place, and it's also been integral in helping audiologists really organize this process in a linear fashion to streamline it for patients and families. And then finally, in 2017, Jordan's Principle came about. That was a federal policy to ensure that Indigenous children received equitable health care regardless of location or status. So there was an attempt to really equalize the playing field between Indigenous and non-Indigenous people. And the huge positive benefit in our area was that it highly encouraged the NIHB to start covering these devices for patients across the country. So the work that we've done through a variety of different organizations, the Sky Building, Regional Audiology, my program, the surgical program, the Universal Newborn Hearing Screening Program, has allowed us to create a new framework for how these patients are processed through the system, for lack of a better term. So the hearing screenings now are, again, offered within 24 hours of birth at the hospital or at home or at the birthing center. That occurs within the first day. If there is a referral for a full diagnostic test for audiology, that's going to occur within a month after birth, and that takes place either at St. Boniface or Children's Hospital, at least in this regional health authority. That will coincide with an ear, nose, and throat medical evaluation. Our goal there is for a 3-month window for them to see the physician. Depending on whether or not there is an opportunity for any medical intervention, meaning an implantation case perhaps, they'll be sent to my program for a candidacy assessment. And that is also taking place within about 3 months of a time window. The assessment includes a lot of hearing aid work, a lot of preliminary therapy, as well as imaging and assessing their potential auditory skills regardless of degree of hearing loss. We move on to the rehabilitation phase, where they're wearing hearing aids and accessing sound with or without the option of surgery. These kids are going to be fit with hearing aids by about 6 months to start accessing that auditory stimulation. If they are a candidate for surgery, they'll undergo implantation by about 10 to 11 months of age. And then families in Manitoba have the option to choose which sort of intervention program that they prefer and works best for their family. And that may include concentrating on auditory and verbal skills. It might include a combination of that and manual communication, or ASL. So we're pretty proud of this process, which it used to take up to 2 to 2.5 years, is now within a 12-month window. I do want to acknowledge the organizations you see listed here. The professionals from those organizations have worked hard over many, many years. Not just the last 10 in trying to create this coherent system. So it's taken a long time, but a lot of very good people working towards that goal. Okay, I'll just take a moment to talk a little bit about our technology. Simply speaking, a cochlear implant is a surgically implanted device that approximates sound by electrically stimulating the auditory nerve through the cochlea. So this is a pretty crude device. I would say that the majority of benefit goes to the patient in that their brain is able to adapt this very crude signal that it receives and turn it into meaningful sound and speech. So the brain is amazing at doing this, because the tool we're using, if you can see on the left here, is an electrode inserted into the cochlea. There's about 20 electrode bands on that wire, and those are stimulating about 35,000 nerve endings. So certainly not a great approximation for natural hearing. But again, the brain being extremely plastic, especially at a young age, our kids do quite well as adults in being able to turn that into to their benefit. Some details on the equipment. The external piece, so that would be the piece you see on your ear or worn over the ear, contains a microphone to pick up the external sound, a speech processor that's going to separate the signal from the noise, and a transmitter coil to transmit that signal over to the internal piece of the implant. The battery compartment is located at the bottom, and that's a rechargeable battery that's designed to last about 20 hours per day before recharging. On the internal side, we have a receiver stimulator. That is what transmits the sound down this electrode, eventually to the cochlea that's exciting the nerve. So how does it work? Very simplified version. Sound is picked up via the microphone, and the speech processor is then converting that to specific patterns of electrical impulses. It's also doing a lot more with regard to identifying what exactly is speech in the environment, what is noise, how loud both of those signals are, and whether that noise is other people speaking. So it's a very sophisticated computer that's running most of the day. The impulses are then sent through electromagnetism to the internal coil. That coil transmits the impulses down the electrode to the electrode array within the cochlea, stimulating the auditory nerve at different rates and locations based on the input signal that the microphones are picking up. And it's doing this pretty much instantaneously. Sorry. With regard to the surgical procedure, it's about a 3-hour procedure here. It's essentially a day surgery. Patients are released for the most part that same afternoon or evening. It's under general anesthetic. Begins with a curved incision behind the pinna, or the external ear. That's done to minimize the visual effects of the surgery. The skin is then spread apart to expose the temporal bone behind. And that's where this mastoidectomy and facial recess surgery or practice comes into play. So that's what they are practicing with on printed bone models before they get to actual humans or cadaver bone. At any rate, the whole point of that 2 hours of drilling is to expose the cochlea and specifically the round window where the electrode is inserted about 25 millimeters into that cochlea. It's hard to see on this picture, but the surgeon's actually working within about 2 millimeter window under microscope. And the facial nerve runs just above that stylet or that electrode, and the chorda tympani nerve, which controls taste, is just below. So damaging any of those nerves is going to result in permanent facial paralysis or loss of taste. So it's a pretty delicate procedure at that point. Everything's packed up. The patient is bandaged for about a week, and then they're activated within about 3 weeks post-operatively. Just a side note on some related technology that exists. We don't tend to use this at all. It's very rare in the field. There's an auditory brainstem implant used specifically for people who may have a lesion or some damage to the nerve more peripheral to the central system. So the electrodes are essentially attached to the auditory nerve much more centrally towards the brainstem. Hasn't proven to be very effective, so it's not widely used, but still exists. Something we do use more frequently is electroacoustic stimulation, and that's the hybrid between a conventional hearing aid and the electrical hearing provided by the cochlear implant. Those are used for patients with potentially normal or near normal low frequency hearing. So their low frequency hearing is quite good, and then they precipitously drop to profound loss in the highs. So the hearing aid will take over the low frequency component, and the cochlear implant will deliver sound for the high frequencies. And generally speaking, the less trauma we can provide to the cochlea with regard to the structural damage results in better outcomes for the patients, so they can rely more on their natural hearing in these cases. We do probably about 3 of these a year. Okay, I'm going to move along here to some bone conduction devices. This is the other half of our surgical program. And these are devices that are much more similar to conventional hearing aids. They are devices that conduct sound directly to the cochlea. Instead of doing it through the ear canal, through an acoustic signal, it uses mechanical vibrations through the skull. These have been around for a long time. We've seen them in eyeglasses, traditional headband type hearing aids. They're used in musical applications for headphones, underwater type of hearing, and then our surgical application with a bone anchored implant and hearing aid. Just wanted to briefly show this confusing chart because just to illustrate, there's a number of different types of ways to deliver sound to the cochlea through this medium. The passive drive essentially means that the sound is generated exterior to the skin and has to pass through the skin and the soft tissue before it reaches the bone. We tend not to like this style of delivery. It has some drawbacks in the amount of high frequency volume you can transfer across to the bone. So you end up having to drive the amplifier to the point where it's feeding back and creating a lot of squealing and whistling, and not very effective for the patient. The direct drive, specifically this percutaneous system, is what we utilize here at HSC. We use 2 different manufacturers. They're both essentially very similar. They involve the abutment, or the little silver ring that protrudes through the skin and then attaches to the device on the exterior. So just wanted to note, the sound is still generated from the outside in this area, but because of the physical attachment to the bone without the skin impeding that transmission, we get a very nice signal to the cochlea. We are eagerly anticipating this active transcutaneous system that is not really out yet on the market, but soon will be, where that sound generator, the oscillator, is embedded in the bone already. So it's that much closer to the cochlea, and that will improve, we believe, the cosmetic aspect of this device and cut down on obviously the skin issues you won't have in an open wound around an abutment anymore. But for now, we're relying on the gold standard, and that system that involves the titanium screw here is effective because the bone essentially grows around that screw and becomes part of the skull. So the sound transmission is extremely efficient. We don't have to drive the device as hard throughout the day. Component-wise, these break down into 3 pieces. The first would be the external sound processor. Again, very similar to a conventional hearing aid. Has a microphone to pick up the sound, an amplifier to make it louder, varying degrees per frequency, and then the receiver, which generates the sound through mechanical vibration into this abutment. The abutment technology has improved over the years. We used to have one standard length that we would have to make work for every patient, regardless of how thick their skin and soft tissue was. That inevitably led to a lot of skin infection issues that we had to treat post-operatively. Now we can select a length of abutment from about 4 millimeters to 14. I know it says 6 there, but I think we have a shorter one. So that's drastically cut down on post-op issues. And then finally, the titanium screw is 4 millimeters, and that is what is actually the implant of this system, drilled directly into the skull. So the surgical procedure here, oops, I'll just get that ready. It's a simple day surgery. It is about 30 to 45 minutes in length. Patients are released the same day, and starts off with a small biopsy hole punch. So there's no incision here, which is nice for the patient, and also cuts down on skin infection issues. Once that hole punch is made, then the surgeon uses this cannula here and a specialized drill to first drill the hole and then countersink that implant and the abutment into that hole. So it's all physical, tactile reinforcement. There's no visual aspect to the surgery. It's just the skill of the surgeon to know exactly how deep to go and rely on the drill and tools provided. So that's what the abutment looks like at the end, and then you can see the attached sound processor up top there. Again, some related technology, not widely used, is a middle ear implant, and it is a little bit more similar to cochlear implant surgery in that you have a long wire that goes down into the middle ear cavity. This attaches to a prosthesis which is placed onto the stapes bone that will physically drive the bone into the cochlea to generate the sound. It's not widely used because it's a fairly invasive surgery. The equipment's expensive, and the type of hearing loss it's designed to treat is really treatable through conventional amplification or bone-anchored hearing devices. So we have tended not to use this one. Okay, so given that information, I just wanted to show you some results. So we are trying as a group to create more evidence-based decision making, and for that we need data to rely on. So I'm going to show some results from the WRHA audiology community, as well as both the newborn hearing screening program and the surgical hearing implant program. So going back to 2010, we had long wait times, long wait lists for pediatric cases. Currently, we are at 0 for wait time to see an audiologist within the WRHA, and that also coincides to 0 patients having to wait. So they are seen extremely fast and processed quickly. There's a lot better communication among different organizations and professionals, and we've built in a lot of redundancy to our system. So there's a lot of checks to know exactly where that child is at any given moment. Hopefully, that's our goal. I'm sorry, that animation screwed up. So I'm going to talk about the newborn hearing screening program. Last year, this is 2017, so last year we had 12,115 babies born in the WRHA. And as I said, the legislation for screening is that they're offered a screen within 24 hours. The acceptance rate for that screen is extremely high at 99%. So in 2017, we screened 11,746 babies. Of those screenings, 455 babies were referred for a full audiologic assessment at about a 3.8% rate. And I know from the manager of the program, Diana Denon, that we're looking for a 4% or so referral rate for a full assessment. So pretty close to that target. And of those 455 babies, 60% of those, once they went for a full test, were deemed to have normal hearing. So that's just a sort of a part and parcel of a screening program. There may be things that interfere with the probe tip. The baby may not be cooperating. At any rate, a large majority of those referred for full assessments were deemed to be normal, which is expected. 97 of those babies, or 21%, had a confirmed hearing loss, and 84, 19%, were either lost to follow-up or not yet diagnosed. So again, parents aren't compelled to show up for further testing, or it may take several appointments to really determine the accurate levels of this child's hearing loss. So let's look at those 97 babies with confirmed hearing loss. my surprise animation is broken. So you can see that 50% of these happen to be unilateral. That's an interesting finding that we're going to track more closely. We typically kind of consider hearing loss to be symmetrical between ears, but we're finding that to be the opposite here. At any rate, out of those 97 babies, 66% or 64 of those babies had a temporary conductive hearing loss. So that is likely related to fluid behind the middle ear. The eardrum and the middle ear system's not as mobile as it should be. Those are largely left to otolaryngology to treat and follow up with. They're typically will resolve in a short period of time. 3 of those babies, or 3%, were found to have permanent conductive hearing loss. That might be a baby who has a microtia or atresia, where bone growth has filled up the entire ear canal, or they're missing their external pinna. So those, we might look at those as candidates for a bone anchored device at some point. And then 20 have sensory neural hearing loss. So this is the cochlear implant potential crew, where they have a deficit in the internal ear, the cochlea, the nerve endings, a permanent type of hearing loss. So of those 20, actually 2 were found with anacusis or profound hearing loss that were deemed to be implant candidates. We subsequently did implant both within 11 months of age. Okay, so why does this matter? Well, for me, it's exciting because we have battled with our average age of implantation for pediatric patients since the program was started. The first year, you can see we had an N of 1 here, so take that with a grain of salt. But that implant age was 5, and I'm just going to fast forward a few years here, and you can see we're hovering around 3.5 to 4. Not ideal. We spiked in 2014 at almost 5 years old again. So this is going to represent a significant delay for these kids and involve a lot more professionals over a longer period of time to help close that developmental gap in their speech and language development by the time they reach school age, and likely will take much longer than that. So not an ideal scenario by any means. In 2016, when our newborn hearing screening program was officially rolled out towards the end of the year, so this one's coincidence, but we started to see a trend downwards to 2017, which was 2.4, and then finally this current fiscal year we're at 1.3. So we really want to keep this age at about 12 to 15 months, no longer than that. Objectively speaking, when we look at, what was a typo here, sorry, how people do with cochlear implants, we assess pre and post-operatively with a best aided sentence score. So it's really their ability to correctly repeat sentences at a level that's appropriate for their hearing loss and with hearing aids preoperatively, with cochlear implants post-operatively. I've segregated these into 2 age groups. Under 70 is the green and over 70 is the blue. So preoperatively, they're scoring pretty low. They're getting about 3 out of every 10 words correct in each sentence. Fairly equitable across ages there, or age groups. Post-operatively, we're noticing that the under 70 age group is trending a little bit better in benefits. So net benefit here is about 40% increase in their ability to understand speech post-operatively. And anecdotally, I can say that really a 10% increase in speech intelligibility equates to a life-altering change for the patient. It puts them from maybe not being able to watch TV or converse with their significant other or family members to becoming part of that community again. So it may be a small number on paper. Certainly a 40% increase is a pretty dramatic change for a lot of our patients. I should have added, I can't really describe what a cochlear implant sounds like You can listen to simulations online. It's everyone's best guess unless you actually use one. But what I've been told is from patients is it's somewhat computerized voice. It tends towards higher in pitch, so voices tend to be a little bit higher. But the brain, again, reorganizes that information and recategorizes each sound into a new bin very quickly after being activated. So you may have noticed here, our over 70 group has a little bit less benefit. And so we dove into that a little bit more closely, and I separated out the 70 to 80 group on the left to the 80 plus group. We have a smaller number of 80 plus individuals, but what we found is that the 80 plus group is actually starting off a lot lower preoperatively. So they're sort of dragging everyone down there with them. Despite that, they both get similar net benefit from the CI. So that 80 group, even though they're starting at 10%, they're jumping up to about 40-45%. So we're still happy to offer this to all age groups and see the benefit therein. Okay, I'll finish up with just a slide about subjective benefits. So we do want to ensure that the implantable devices that we're putting in people are creating net positive changes in their lives. This is a 24-item questionnaire we give all of our bone-anchored hearing device patients. And it essentially asks them to assess how well they do in a variety of very common environments that you might encounter in your daily life. So talking with a friend, going out to a restaurant, listening to someone talk at a podium. So we ask them, before surgery, how well are you doing in these areas? 1 would be they're not doing well at all. 7 would be they have no difficulty in those environments. So you can see on average among 40 individuals that's pretty low. Post-operatively, they jump up quite a bit, significant in each category. So we're fairly confident that this is a change that is worth the expense for them, worth working with some of the drawbacks of an implantable device and the cost. So moving forward, I guess in the next 10 years, I think what we're going to see is an attempt to really create a lot more data to drive our decision making in the future. We do want to work on extending these concepts outside of the Winnipeg Regional Health Authority, tailoring it to each independent region based on their population and locations of care centers. We ultimately want to try to increase access for folks across the province. So a lot of work to be done, but at least we've seen a nice positive change to date. So that's what I have for you today. Thanks very much for your time.
At this time, if there's any questions for Justin? Archie.
What's the main limitation to moving forward with the next steps?
Well, I think time, money, and people would be my top 3. A lot of the work that I've talked about this morning is really in addition to our regular jobs. So we're sort of trying to drive the policy and the access in and around what we do on a daily basis. I think money with regard to technology, access to telehealth technology, internet, that's going to help expand care to more remote areas. So that's been holding us back as well. And then just people in those areas, being able to provide that on-site care is certainly a limitation currently. Yep.
You touched on some of the barriers just now about perhaps delivery to some services to First Nations people. Can you talk about some of the other barriers? You talked earlier about funding. Is that still a barrier?
Well, I think maybe this is one area of healthcare that's been
seeing a positive change with regard to funding. I think certainly our programs are not cheap, but provide a good cost-benefit ratio for the people in Manitoba. If we can capture these kids much earlier, that's going to decrease the cost in the longer term. And also, we're enabling people who may not be able to work to regain their livelihoods in their vacation modes. So I think certainly funding with regard to staffing levels, we have, I think, 63 audiologists in Manitoba. Probably half of those work for the public system. Certainly could use, I would say, double that in more
northern remote areas. So it's a hardship on the families, on the kids. It creates longer wait times, inconsistent care with regard to appointments, and I think I always like to try to recruit audiologists from Manitoba who are studying outside of Manitoba because we don't have a graduate program here. But currently that number is 2 across Canada, so we have a very limited pool of recruits coming up the pipeline. So I guess that would be another barrier for me.
When you're talking about funding, the initial CI is funded for kids. Is the processor funded for are they funded for a second processor? Or?
That's a great question. I forgot to mention. Thanks. Our program provides the internal implants, and for kids it will provide 2 external sound processors for each ear. So if that child is bilaterally, they'll get 4
processors as a backup. Adults don't receive the backup at all, but we do provide the initial processor at no cost. That's the same for our bone-anchored hearing aid program. Yep.
So your program is a program of the WRHA. Do you get children from other RHAs coming in for service?
Yeah, we would accommodate all children, all patients in Manitoba.
Do you have any statistics about the breakdown? Is it like 90% WRHA, 10% everybody else?
It's about, I don't have a specific number, but I know it's around 55% or 60% within the WRHA.
Okay.
You have quite a few from the Southern Health region. I'd say that's the second biggest block.
What would be the most common adverse event that occurs with this surgery?
The cochlear implant surgery?
There are a few. I guess because we're opening up a direct pathway to the brain, there's a risk of meningitis infection. All of our patients are vaccinated prior to surgery for that. I mentioned the insult to the facial nerve and the trigeminal nerve, or corticotympany nerve, sorry, which thankfully we haven't had. Beyond that, I think it's just related to general anesthetic. We've had a few people who we've had to stop in advance of surgery, 2 people in fact, just because they weren't fit for the anesthetic. So the risks are fairly minimal. We have a 2% complication rate, and those are really related to wound management afterwards. So like peripheral infections, that sort of thing. So.
Sorry, Justin, I got to bait you with a couple of questions.
Sure.
If any one member of this audience becomes deaf, and I'm assuming all of them are perfectly functional, what's their wait time to surgery for cochlear implantation?
Sure. So this year,
we are at 14.5 months for an adult.
Implantation.
30. Right now we have 38, and we accommodate. Our device budget is a big envelope for both pediatric and adult candidates, and kids don't wait, so we reserve an allotment for them. but about 2/3 of our cases are adults, and that comes out to between 25 and 28 adults per year. So we know right now there's going to be at least 10 more people waiting a full calendar year until they're eligible to go.
Working and not functional. My last question for you is, how many allocations of cochlear implants are there per year and bone-anchored implants per year? And what do you think is an appropriate allocation for a service provider that provides care to 1 million plus people in the province of Manitoba, Northwest Ontario, and other parts of Nunavut, including First Nations patients?
Yeah, I would say it's
Currently probably a little inadequate. We have, so I mentioned earlier, our budget, depending on the year and the contracts we've worked out with vendors for pricing, can accommodate about 40 cochlear implants per year and about 14 bone-anchored hearing aid implants per year, 14 to 15. I think that currently we're slightly, we could use a slight bump to accommodate people right now. What we have to look forwards to is planning ahead for those revision surgeries. So these implants will last about 20 years internally. We're implanting kids now at age 1. They're lifelong patients, so every year we're going to start seeing more and more revision cases where their internal piece has failed. Further compounding that will be adults demanding bilateral implants. We're seeing that very frequently now, and it's hard to argue with that. We know 2 ears are better than 1 with regard to hearing. It's why we apply that to our pediatric cases. Looking forward, I think we need to really start planning for increasing the budgets on both sides of things, because these patients are now ours, and we need to continue to take care of them for quite far into the future.
How many adults are you implanting after meningitis?
Not that many. I can think of right now maybe 4 or 5 cases over the last 5 years. We just had one in Brandon who had she had meningitis and lost all vision and hearing overnight. That was the most recent case. So we actually implanted her bilaterally within 3 months of the infection. So she's doing quite well.
If there are no more questions, thank you very much, Justin, for your presentation today. It was very, very interesting.
Good.